Good afternoon, and thank you for joining us today to discuss Medicare billing for mammography services. My name is Karen Curtis, and I am a member of the Provider Outreach and Education team here at WPS. I'm joined today by my co-worker, Jennifer Boniface. Each month, Jennifer and I hold webinars discussing Medicare coverage of different preventive services. I talk about the billing part of the service, and Jennifer, who is an RN, discusses the clinical aspect. Since October is National Breast Cancer Awareness Month, I found it appropriate to talk about Medicare coverage of mammography services. And on October 7th, Jennifer will be holding a webinar on the clinical guidelines for screening mammograms. So if that's something that you're interested in learning, then be sure to check out our live events page so you can register. I have a couple of things to cover before we get started. First, if you haven't downloaded a copy of today's presentation and you would like to, there is still time. A copy can be found on our live events page, which is located within the WPS Training Center, along with a list of our upcoming events. Jennifer's going to add a link into the chat, and that'll get you there quickly. Our training center also contains a web page for our encore presentation. Videos are available for up to 90 days and can be watched on our website without having to go to YouTube. We know that some of you may not be able to access YouTube from your company computers, and we want you to be able to receive the education that you're interested in. Each encore is posted with a link that will allow you to download a copy of the presentation. You will also be given another chance to complete a survey and provide your feedback. Today's presentation is being recorded, and if there are no technical issues, this will be posted to our website soon. Later, there will be a question and answer session if time permits. If you have questions related to today's topic, please send those in using the chat feature. If there's any questions that I don't get to, or if some require additional research, I'll send an email providing the answers to everyone that is in attendance today. Our goal is to provide you with an excellent customer experience. We want to know how we are doing, so later in the presentation, you'll be given the opportunity to provide us with feedback. This is your chance to let us know what we're doing right. Let us know if you feel that there are areas where we can improve. And it also gives you a chance to give us input on what type of education you'd like to see in the future. While this is a CMS survey, WPS does look at our results, and we do our best to make the improvements that you ask for. Here at WPS, we do our best to provide you with accurate, up-to-date education. If you've worked in Medicare for a while, you know that Medicare rules and regulations can change. For this reason, the CMS website should be checked for updates, and the federal regulations take priority over anything presented today. We do answer questions based on the facts given, so any changes to that information may change the response given. We are also not able to guarantee payment for services. Medicare rules will always determine final coverage of service. Now, if you have a claim-specific question, we do ask that you contact customer service. The Provider Outreach and Education team doesn't have the ability to access the system, and since customer service can do that, they'd be able to provide a better answer according to how your claim processed. Lastly, I need to let you know that CMS does prohibit recording of this webinar, and as I stated earlier, we are recording the event so that it can be posted on our webpage and YouTube channel as an encore presentation. Today, I'm going to provide some general information about breast cancer, then we'll move on to Medicare coverage and billing, and finally, we'll discuss eligibility. Now, the world of Medicare contains a lot of acronyms. I've created a list of those that you will see or hear during my presentation, and many of you may be aware of most, if not all of these, but I like to include them in case there's someone who's maybe new to Medicare, or maybe someone who works in a field or practice where they just haven't had to know what all of these mean. If I mention any acronyms that you're not familiar with, you'll have these slides to review. Now, this is the American Medical Association's copyright notice for CPT codes. During this presentation, I will provide billing information which does contain CPT codes, and this notice just lets you know that Medicare does not own CPT codes or their descriptions. Again, another notice. This is a copyright notice from the American Hospital Association National Uniform Billing Committee. This notice is required since I discuss coding that would be included on a UB04 or an 837I. The American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information provided today. Now, let's get started with some general information. Rates of breast cancer can differ between sexes, ethnicities, and ages. The Susan G. Komen organization estimates that this year there will be over 310,000 new cases of invasive breast cancer in women and around 2,800 new cases in men. Along with that, there will be close to 43,000 deaths. When we look at the risk factors, there are some that are just out of an individual's control. These can include getting older, breast cancer, the risk of breast cancer increases with age, and most cases are diagnosed after the age of 50. Genetic mutations. Those who have an inherited gene mutations such as BRCA1 and BRCA2 seem to have an increased risk for both breast cancer and ovarian cancer. Women who start menstruating before the age of 12 or who start menopause after the age of 55 are exposed to hormones longer, which can increase their risk of developing cancer. Dense breast is another uncontrollable risk factor. Now, this occurs when the breast contains more dense tissue than fatty tissue, and this tends to occur in younger women or individuals with a lower body mass index and women who may be taking hormone therapy to relieve symptoms of menopause. Having a personal or a family history of breast cancer can put you at increased risk. Women who have had radiation therapy to the chest or breast before the age of 30 have a higher risk of developing breast cancer later in life. And lastly, exposure to the drug DES. This drug was used in the US between 1940 and 1971 to prevent miscarriage. The CDC reports that women who have taken DES have a higher risk of getting breast cancer. They've also found that women whose mothers took DES while pregnant with them may also be placed at a higher risk. So next we're going to look at some controllable factors. Now, this is where education could help individuals make changes to improve their health. Physical activity is the first. It has been found that women who are not physically active have a higher risk of getting breast cancer. Women who are overweight or obese after menopause have found to be at higher risk, as well as those who may have been put on hormone replacement therapy. Women whose therapy included taking both estrogen and progesterone for more than 5 years could be at increased risk for developing breast cancer. This has also been found to be true for birth control pills. Reproductive history is another factor. It has been found that women who have their first pregnancy after the age of 30, who don't breastfeed, and have never had a full-term pregnancy can be at increased risk. Finally, studies have shown that alcohol consumption affects a woman's risk. The more a woman drinks alcohol, the more her risk for breast cancer increases. I wanted to talk a little about facility certification. The Mammography Quality Standards Act gives specific standards in regard to who is qualified to perform screening and diagnostic mammograms and how they should be certified. All facilities, except for VA facilities, that provide screening and diagnostic mammograms must have a certificate issued by the Food and Drug Administration in order to operate. The FDA then provides CMS with a list of all certified providers who will in turn notify the Medicare contractors. MACs are also notified if a provider certificate has expired or has been suspended or revoked. When services are provided under arrangement, the provider arranging the service must make sure that the facility performing the service has been issued an MQSA certificate by the FDA. Screening mammography x-rays should not be released for interpretation to physicians who are not approved under the facility's certification number, unless the patient requests a transfer in order to obtain a second opinion, or if the patient moves to another area where the next screening mammogram will be performed. Medicare will only reimburse FDA-certified facilities. Now, the FDA sends the USA file to CMS on a weekly basis. Facility name and certification. A record type of 1 shows that the facility is certified for film, and a 2 shows that a digital certification has been obtained. This file also contains effective and termination dates for each certification, and a T if the facility has been terminated. If a facility finds this file to be in error, then they would need to contact their regional office mammography coordinator, who will then contact the FDA. So that would be something to keep in mind if you start getting denials. Now we'll go ahead and move on to coverage. Medicare provides coverage for both screening and diagnostic mammograms. Screening mammograms are used for the early detection of breast cancer by detecting changes in breast tissue. Patients do not need to be experiencing any symptoms to have a screening mammography. These are usually 2 or more images taken, a top and a bottom view and a side-to-side view. And it also may take several days for the images to be evaluated and findings reported to the doctor. I know a lot of times when I go, they tell me that it can take up to a week for me to get my results. During a diagnostic mammogram, several images are taken from multiple angles. These mammograms are ordered to evaluate abnormalities that may have been found during a screening mammogram, or maybe the patient has signs or symptoms indicating that they have breast cancer. Unlike the screening, digital mammograms are usually evaluated while the patient is still at the facility. That way, if they find something, maybe the pictures didn't turn out as well as they like, then that person would still be there in order for additional pictures to be taken. Annual screening mammograms are covered under Medicare Part B for women over the age of 39. Copays, deductibles, and coinsurance are waived. A doctor's prescription or referral is not necessary, and coverage will depend on the woman's age and frequency. Medicare will pay for one baseline mammogram when performed between the woman's 35th and 40th birthday. Women over the age of 39 can receive yearly screenings as long as 11 full months have passed since the last mammogram. So if the beneficiary received their annual mammogram in January of 2024, then they would not be eligible again until January of 2025. Diagnostic mammograms are also covered under Medicare Part B for men or women with signs or symptoms of breast disease, a history of breast cancer, or if the physician feels that it's warranted based on the patient's history and other factors. Diagnostic mammograms do require an order from a doctor of medicine or osteopathy. So now let's talk about what you need to put on your claim in order for it to be sent to Medicare. Here's a list of the CPT and HCPCS that can be added to your claim. This includes screening, diagnostic, and tomosynthesis codes. In situations where a screening mammogram leads to a diagnostic mammogram, then modifier GG should be added to the claim to show that both tests were provided to the same patient on the same day. Well, Medicare will pay for both tests, and the modifier is needed for tracking purposes. Now, if you're interested in getting more information on modifier GG, my co-host Jennifer will cover this topic in our Modifier Monday series on December 9th. So be sure to keep an eye on our live events page so that you can register for that. When billing for a screening tomosynthesis, the claim must also include code 77067. So this service is not payable when it's billed alone. If the service is billed without the 77067, FIS will return the claim to the provider for corrections, and MCS will deny the claim. Also, if the mammogram were to fail common working bowel age or frequency edits, then both of the services on the claim are going to be rejected. If you're billing a digital tomosynthesis, claims should contain the 77065 or 77066 along with code G0279. Both FIS and MCS will deny claims that do not contain both codes. If you are a provider who bills using the FIS system, then code G0279 should be submitted with one of the revenue codes listed on this slide. If one of those codes is not used, then the claim will be returned to the provider for correction. This also applies if the claim is not submitted using one of the type of bills listed here. For screening mammograms, claims should be submitted with diagnosis code Z1231. If you bill on a UB04 or an 837I, and this is the only service provided, then the Z1231 should be placed in the principal diagnosis code field. Now, if there are other services included on that claim, then the code can be listed as one of the other diagnostic codes. For diagnostic mammograms, I've provided a link to the Medicare Claims Processing Manual. It's Chapter 18 on Preventative and Screening Services. Now, the list of what Medicare would consider was 5 pages long, so I just thought it would be easier if I just provided a link for you to view. Here you'll see a list of the applicable type of bills for claims being submitted through FIS. Screening mammograms should be billed using Revenue Code 403, while diagnostic should be billed with Revenue Code 401. If a screening mammogram is self-referred and an attending physician NPI is not available, then the facility NPI should be used in the attending physician identifier field. There are some different rules for rural health clinics and federally qualified health centers. For independent RHCs and freestanding FQHCs, the technical component of screening and diagnostic mammograms is outside the scope of benefit. Now, the practitioner who provides the technical service would be eligible to submit their charges on a CMS 1500. The professional component of the screening and diagnostic mammograms is within the scope of benefits for RHCs and FQHCs. Now, provider-based RHCs and FQHCs, independent RHCs, and freestanding FQHCs should bill on type of bill 17X or 77X with revenue code within the 520 range. No payment will be made for lines that contain revenue codes 403 or 401. For a diagnostic mammogram, no payment will be made for the professional component unless there is a qualifying visit on the same day. If a non-digital screening mammography is provided, claims should be billed on one of the type of bills you see listed here with revenue code 403. MACs will take into consideration the presence of a high-risk diagnosis, if appropriate, the date the patient last had a screening mammography, and the age of the beneficiary when considering payment for these services. If you submit claims using the CMS 1500 or 837P, charges for the technical component should be billed with modifier TC, and physicians who bill the professional component separately should include modifier 26. In the case of self-referrals, providers should submit their own NPI in place of the attending or referring physician NPI. Now, the last topic I'd like to cover today is eligibility. We want to make sure that you know how to avoid getting your claims denied with frequency edits. There are a few options for checking eligibility. The first option is the secured portion of the WPS website known as the portal. This option contains a Preventive Services tab, which will show you a patient's next eligibility date. I do want to let you guys know, since you probably may notice that the IVR is not listed here. On Friday, September 27th, CMS issued CR 13754, notifying contractors that they have until March 31st of 2025 to disable beneficiary eligibility from the IVR. I'm going to have Jennifer add a link to the transmittal for those of you who would like to read it. So this means that providers are going to have to check eligibility using online tools and services. And we do plan on holding some webinars later to prepare for this change. We know that as we go through these next few months that questions may come up, and we want to make sure that you have the answers you need. Providers who bill using FIS can register for DDE or direct data entry access. This option provides common working file screens that list preventive services codes along with their next eligibility date. And our teammate Aline has been holding some webinars on direct data entry. So if that's something that you want to know more about, you can check our Encore Presentations webpage and our YouTube channel. Lastly is the HETS, or the HIPAA Eligibility Transaction System. Now, this requires you to be enrolled as a direct trading partner with WPS. And after submitting a 270 eligibility request file, then you're going to be provided with a 271 response file. And that's going to include the codes listed for preventative services and their next eligibility date. I've also provided some resources for you just in case you want to get more information regarding mammography services. Now, before I ask Jennifer if we've received any questions through the chat, I did receive one question during the registration process, and the question read, male mammograms excluded for coverage, but how does condition code 45 affect this? So I want to start out by clarifying that while males are excluded from coverage from the annual screening mammographies, they are not excluded from diagnostic mammograms. So for any procedure code that is considered to be appropriate for one gender but not another, there are condition codes and modifiers available when the individual's experienced gender does not match their sex at birth. So providers who bill on a UB04 or an 837I, condition code 45 should be added to the claim. For providers billing on a CMS 1500 or 837P, then modifier KX should be added to the line containing the gender-specific service. I'm going to have Jennifer add a link to a Medicare Learning Network Matters article for those who'd like some more information on this topic. So now that I've answered that, I'm going to ask Jennifer if we've gotten anything, any questions that have come through in the chat.
Yes, Karen. We actually got two questions, but I did answer one privately because it was very specific just to that provider. But the other question we did receive, someone, let me see. Sorry about that. Nikki has asked if you could go over the frequency once again.
Sure. So for the frequency, for the annual screening mammographies, 11 full months have to have passed from the last screening mammogram. So if a beneficiary came in January of 2024, then the 11 full months you'd start counting in February. So that means that they would be eligible for their next mammogram in January of 2025. So hopefully that clears that up.
And so far, that's the only other question in the chat.
Okay, thank you. Now, after the close of today's webinar, you are going to receive a thank you for attending email. And here is where you're going to find your proof of attendance and contact hours for continuing education units. This email also contains a link which will give you another opportunity to provide feedback. Now, if you don't get this email, check your spam or your junk folders. You'll also need to add the messenger@webex.com to your safe sender list, and that will avoid you, or should avoid you having any issues in the future. Now, if you joined only by phone, you're not going to receive this email. So if you are one of those people that only dialed in, please send an email to the wps.gha.education@wpsic.com email address and include your name and the phone number that you used to join. And that way we can get a certificate sent out to you if you need one. Now, if you think of any questions after this webinar, you have 7 days to send those in. You can email those to the education mailbox shown here on the screen. And be sure to put today's topic in the subject line so that my team members know that your question is related to this webinar and they'll send it directly to me. Now, remember, if that question is claim specific, then those should go to customer service. When you disconnect from the webinar, you're going to be redirected to a CMS survey. I'm also having Jennifer add a link in the chat. And we just want you to know your feedback really does mean a lot to us. We review what you have to say and we do our best to make the changes that you ask for. This is also an opportunity for you to let us know what topics you would like us to see provide education on in the future. So if you have a suggestion, please be specific so that we can get you what you want. Also, if you have ideas that you think would improve how you receive our education, be sure to tell us that too. The redirect looks like what you see here on the bottom right. We don't have any control over how this appears, so we just want to make sure that you know that this isn't spam or anything malicious. That brings us to the end of today's presentation. On behalf of myself, Jennifer, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.